There you go. Exciting. So can you all see my presentation?
Yes.
Yeah.
Yes.
Well, welcome everybody. Thank you for joining me on this Thursday evening. Obviously I know a few of you on the call. For those of you who don't know me, my name is Clayton. I'm a physio at a Peri-Physio clinic, and I've been qualified for about 17 years, and as of 2020 became one of the directors in the clinic. I'm predominantly musculoskeletal physio and completed my master's back in 2016, but also do some work with oncology, cancer rehab patients, and more recently, over the last 6 years or so, women's health, primarily because the physios that used to run the service left, and so I picked up the baton to carry on. I am an ex-PACES member, so some of you may know me, so I'm not, but I do support you in spirit, even if I don't do your races and events. And in my spare time, I run, cycle, swim, dabble in a bit of triathlon, and do a weekly body pump class with Hazel, who's also on this call. So it's designed really for anyone who participates in sport, might be a physio, PT, and I've been doing a hormone course with another women's health physio called Michelle Lyons, who's a bit of a guru with all things women's health, and it covers topics from menstrual years, perinatal, postnatal, perimenopause and postmenopause, which is what we're going to cover today, and also add in some bits and bobs about Red S as well, which is a little bit more applicable to running, endurance sport, but we'll cover that shortly. The session is recorded, so we are going to be starting up hopefully a Peri-Physio podcast, and this will be recorded and uploaded onto the YouTube channel, which is on our clinic website as well. All the details will be at the end of the presentation. For some of the images in the presentation, I have asked permissions for them from Michelle Lyons, and also from a lady called Kirsty Elliot, who is a researcher in pelvic health at Manchester Metropolitan University, and there's some quite good papers that she's produced. One of the tables at the end is a little bit more applicable to coaches in terms of the considerations for female athletes as well. So I'll give you the links if you want to have a look. And there's also some quite good resources for women's health podcasts. At Your Cervix is one that I've listened to quite a lot. And again, the details will be at the end. So although a lot of this refers to athletes, it does include those who exercise for fitness. You don't have to be an athlete, although a lot of women's health studies do focus on this particular population. In our own ways, we're all athletes really, depending on whether you're grassroots or elite. At the end, we're also going to have some additional information from Emma Robinson, who is also on the call. Emma has a Bachelor of Science in Nutrition and a Master of Science in Nutritional Therapy, and we'll be talking about nutrition and lifestyle tips for hormonal balance. So there's a little bit of overlap with some of the things that we'll cover. At the end, I've popped on both our email addresses. We very much value your feedback if you wouldn't mind emailing. And also if you have any suggestions for future topics of talks, quite happy to put some sessions together. I mean, most of these topics we cover menstrual health, postnatal, perimenopause, or you could do an entire talk on them in an evening anyway. So it's a bit of a whistle-stop tour, but if you've got particular areas you'd like more information on, let me know and I will do some homework. So on to the next slide. Generally, women's bodies change throughout our life stages, really, and having a good understanding of hormone change is really quite important, but more essentially, what is normal for you as an individual and maybe how that changes through your lifespan. It's quite good to have an understanding of menstrual health, hormonal health, really for symptom management and knowing when things are changing. So that really applies more to women perhaps who aren't on birth control or contraceptive pills, who do have regular cycles, which we'll come to. As you then get closer to perimenopause, it can be easier to know whether things are starting to change. But as you can see on the slide, the hormones that we're going to cover really are estrogen, progesterone and testosterone. The menstrual cycle will come on into the next slide, but the reason it's quite a focus on it is because back in 2015, ACOG, which is the American College of Obstetricians and Gynecologists, classified it as the 5th vital sign to health, women's health particularly, along with heart rate, temperature, breathing or respiration rate and oxygen saturations. Again, looking at exposing the female body to normal monthly hormonal fluctuations, and if those start to change, again, if they're not controlled through hormonal contraception, then having an awareness of any changes is quite key. So it's really quite important to understand menstrual health for women and men, really. And to be aware of what your normal is. So there's a lot of talk in research of N equals 1, which is really knowing what is your norms for your own body, and looking at any changes. We'll also, look at some postnatal changes to the body and touch on some phased return to activity and exercise. Also be aware of changes in perimenopause, so the winding down, if you like, of fertility and function, and then postmenopause, when you have a steadier drop in hormone levels, possibly with some symptoms from perimenopause. But all of these really are looking at living well throughout the phases in our lives and then beyond into aging. So for the women on the call, if you're not on contraception, track your periods. It's quite a sort of focal point that will run through the talk probably. Really to know what your normals are. I'll talk a little bit about durations of menstrual cycles and how they vary, but you can use lots of apps, free apps, the Balance app, you can use a calendar, you can write it down, and just get a sort of pattern of what your normal sort of cycle duration is, and then also monitoring any symptoms, premenstrual stuff as well. So understand what hormones do for us females and how to look after them is what we are going to talk about. For any physios or PTs, personal trainers in the talk, or maybe coaches, something to ponder. If you're not already doing so, do ask female athletes about their periods. There's a lot of pelvic health issues, endometriosis, polycystic ovaries and things like that can present as musculoskeletal issues, hip pain, back pain, groin pain, abdominal pain. And so sometimes on differential diagnosis or trying to understand what the source of symptoms are, it might actually be something that's more women's health related as opposed to a mechanical back pain, for example. So it's always quite useful to get some additional information about symptoms relating to pelvic health, hormones, and if there is any sort of lower back, hip pain, for example. For coaches, it can also give an indication of training and injury issues, which is something we'll come on to with the Red S section as well. So we'll come back to that. What do hormones do? Some of you may know, some of you, we've got a bit of a recap. So estrogen, on the left side of the slide, is one of the main female sex hormones, and it's pretty incredible. It has about 400 functions in the body, which is slightly unfortunate given that it starts to decline as we age, because it has quite a lot of influence on a lot of our body functions. It's an anabolic chemical, I guess, so it actually promotes muscle growth, but it can make tendons less stiff. So when you're looking at your menstrual cycle peaks in estrogen, when you come up to ovulation, being aware of this, if you're an athlete yourself and training, you might find there's a little bit more risk of injury, if sort of rest, recovery, training isn't balanced. And estrogen is also has an anti-inflammatory function as well. It has an effect on quite a lot of structures in our body. So you've got muscles, tendons, bones and bone health, ligaments, heart health with the endothelial cells, which are your heart cells, and estrogen is very cardioprotective. So when we come on to the menopause section, we'll touch a little bit on risks of lower estrogen and heart health issues. It's brain protective, so brain health, digestive issues, it has functions with, sexual health, mood, and for women's health specific things, it also has some influence on bladder, so stress urinary incontinence, which is predominantly a postnatal consideration, but not solely. Often postnatally, bladder leakage is common, but it's not a normal thing to have to endure for the months after birth. Stress urinary incontinence is where there's often leakage on high pressure, increased intra-abdominal or middle trunk pressure, coughing, sneezing, jumping on a trampoline, for example. And the urge incontinence is the urgency to get to the toilet, often referred to as like the front door key syndrome. You kind of needed a wee, and then you really, really needed a wee when you got to the door. And then also bowel and pelvic pain, estrogen has some influence on. Progesterone, its sort of function is given away by the name a little bit. So progest, it basically wants to prep the body for pregnancy, but it does have a function to keep estrogen in check. So too much estrogen is not good, but you can think of the sort of hormone balance with estrogen and progesterone as like estrogen is like grass growing in the summer, grows a lot, and then progesterone is like your lawnmower, so it will keep tabs on the balance through the cycle, which we'll cover in the tick. Progesterone is also produced by the corpus luteum in the second phase of the menstrual cycle, which I'm going to come to shortly. Not to forget testosterone. It's produced in the ovaries and the adrenal glands, and it's released into the bloodstream. It has a good function, it maintains bone mass, and is also important for brain function and muscle health as well. It can help generate new blood cells, and also maintains libido, vaginal health, and regulates mood. Women typically can't get too buff with the amount of testosterone that we have. We only have about 1/10 of the level of testosterone compared with men. So if you're doing strength training, it's physiologically impossible to end up looking like the Michelin Man, unless you're on some sort of substance. So getting a good balance of those hormones is quite key. There are also some diet considerations with sex hormone production. Again, we'll touch a little bit of that in the Red S section, and Emma will probably also cover some bits at the end. We need healthy fats in our diets to help produce sex hormones as well. Cholesterol tends to get a bit of a bad rap in the press, but it's actually quite essential in our diets for this function. So if there are elements of restrictive food intake or overtraining, then these sorts of foods are not necessarily taken on, and that can also influence the production of the sex hormones. So on we go. to the menstrual cycle. So again, these are from these images from the Kirsty Elliot Sale 2019 paper, which is called Considerations of Coaches Training Female Athletes. And also the chart near the end is also from there. It's a little bit small on the screen, but quite interesting to look at what kind of exercise is perhaps slightly more sort of beneficial to the body at certain points in a menstrual cycle. So the menstrual cycle typically varies in duration from female to female, and also sometimes for a female, if there's stress, life events and things, that can sometimes alter it a little, but normally somewhere between 21 and 35 days, and that generally applies to women not on contraception. And there's 4 phases. We also have a sort of uterine and an ovarian cycle, which sort of run hand in hand, really. So if you're looking at the menstruation phase 1, the cycle starts really on the first day that you get fresh red blood when your period starts, and that normally again lasts for about 5 to 7 days, and this is when estrogen levels and progesterone levels are quite low. You then move into the follicular phase, which is technically the first half of the cycle, and that's roughly 11 days long. Estrogen starts to rise, so you often feel quite good, like you want to conquer the world, for example. And the pituitary gland triggers a release of FSH, which is follicle stimulating hormone. Testosterone also increases a little bit here as well. And so when you're looking at, I mentioned the table at the end of Kirsty's research paper, type of exercise you might want to do in certain phases of the cycle. Strength training is quite good in this phase. Tendons love estrogen, and obviously that's starting to increase. Also, you might find that athletic performance increases. You might get a PB or a strength training record on a lift, for example. In this phase, there's also sort of increased endurance, pain tolerance, and also insulin sensitivity. And there's some evidence that carbohydrate metabolism is also better in this phase as well. Then we come on to ovulation, so the big peak in the middle of the graph, can't miss it. And it's not always on day 14 of your cycle. There's a lot of information online that typically classifies a cycle as being 28 days long. On ovulation's day 14, it's absolutely rubbish. So that's why tracking cycles is quite important, because it gives you an idea. If you're not sure, there are these apps that you can use, but typically from a physical perspective, when you're at peak ovulation, which is maybe 3 or 4 days, your temperature is a little bit higher in the morning, and also your cervical mucus is much thinner, like egg yolk. So that can give you an idea of when you're actually at peak ovulation. During this phase, luteinizing hormone, or LH, is released, and that stimulates a follicle to release a mature egg. So after that egg is released, that leftover follicle then transforms into the corpus luteum, and that actually acts as a temporary endocrine gland, so a hormone gland, and that's where you get some of your progesterone production from, as you then come into your luteal phase, which is the second half and the last part of the cycle. So that's roughly 11 to 17 days long. Estrogen is declining, so the corpus luteum pumps out your progesterone, which it does for about 12 to 14 days. Basically, your progesterone is prepping for a possible pregnancy. So if there is no fertilization, your corpus luteum stops your progesterone production and dies after about 2 weeks, 14 days. And then your uterus lining sheds and you get your period and the cycle starts again. So again, if you're looking at your exercise preferences, you might find that cardio exercise is preferable. Fat oxidation is slightly better in this phase as well. And because of the increase in progesterone and that preparation for pregnancy, often women get the munchies, and your appetite increases. So that's why that can sometimes have that ebb and flow through the cycle. Again, if you're not on hormonal contraception. Premenstrual symptoms, again, can be fairly vast, but typically might be bloating, mood changes, diarrhea, cramps. Those are typically caused by your prostaglandins, which are the same chemicals that your body produces in labour, slightly less intensely though, as I am led to believe, and that's what causes the uterus lining to shed. So it gives these like mini contractions through the uterus, which is where the cramps come from. In this phase, you might want to monitor bowel changes, or you might notice bowel changes. So there might be some diet modification to happen. So establishing any triggers at that kind of premenstrual phase, like spicy food or fruit, can actually be quite useful. It's often known as the period squits. I mean, there are other words, but I probably can't say them on here, where basically, because the prostaglandins are so close to your bowel and it's clearing out the contents of your uterus, it will also clear out the contents of your bowel as well. So dietary wise, you might want to find some foods that don't go straight through you. Interestingly, your premenstrual symptoms can give you a little bit of an insight into some of the perimenopausal symptoms that you might experience later in life if you are not yet 35 years old or over. I'll come on to that shortly. A side note though, for periods, painful periods are not normal. So do get sort of pain associated with periods investigated. 1 in 10 women will experience endometriosis, and often that can take quite some time to diagnose as well. So if periods are affecting school or work, you get bladder pain, pain during sex, irregular, light or very heavy bleeding, chronic yeast infections, abdominal or pelvic pain, IBS, bloating, gas or constipation that's sort of much greater than it would be at other points in your cycle, then do get that looked at, either through your GP or a gynae specialist. So it comes back really to tracking your cycles, know what is normal for you, use diaries, apps, and monitor any significant changes as well. Move on. Too far. So regulating hormones. Again, you can apply these elements really if your hormones are not very regular. So that might be if there's a bit of red S going on. It might be if you're postnatal, or if generally your cycles are a little bit all over the place. How do you regulate hormones? Again, there's a little bit of overlap with Emma a little bit later on in terms of nutrition. But the main key things, certainly that Michelle Lyons was talking a lot about, are getting adequate sleep and rest, good gut health. She's quite obsessed with bowel movements, is Michelle Lyons. So there's a lot on gut health, and there's quite a lot of evidence around at the minute with gut health and brain health, the link between gut and brain as well. So good diet and hydration levels, stress management and movement. So again, looking at your cardio, strength training and mobility work as well. It sounds quite simple and straightforward to say those things are the list, but in essence that is sort of the things that you can cover before you might have to look at anything more medical or with any other medical intervention. So if you've given all those things a go and things are still not quite right, then certainly do get them checked out. For sleep, we're going to cover a few bits for general population, postnatal women and perimenopause, because there's some slight differences that occur at those life stages. Generally, when we sleep, that is when our recovery happens. So it gives your cardiovascular system and heart a chance to rest after your training, however intensely that may be. And that's also when your cell and tissue repair happens. Muscles generally release protein building amino acids into your bloodstream, generally at an increased rate as well during sleep. And that's when it promotes your muscle hypertrophy, so the increased growth of muscle cells. Ideally, you're looking at somewhere between 7 or 8 hours. Some postnatal women might be thinking, no chance. But if you're getting 4 to 5 as opposed to 7 or 8, it can be detrimental to your body's ability to maintain muscle mass. So it can be tricky to balance. But your heart does like consistent and regular sleep. So if you're experiencing insomnia, sometimes that can have links with other issues like high blood pressure or heart disease as well. So trying to tackle sleep management things I'll cover in a little while, but trying to improve quality of sleep is quite key. For postnatal women, in that postnatal period, if you're breastfeeding, particularly, estrogen levels remain low. So it is one of the ways your body naturally tries to prevent pregnancy. However, that's not necessarily foolproof. So don't rely on that as a form of contraception. But that can have an implication on activity levels and energy levels from the lower estrogen levels, but also your poor sleep. And maybe impact on training and exercise as well, or at least the motivation to want to do it. Sleep deprivation also impacts on appetite and appetite suppression and satiation. So you've got two different hormones, leptin and ghrelin, which monitor your appetite and suppression. And they can get a little bit off balance when you're not getting your normal sort of circadian rhythm, sleep cycle occurring. And also that can sometimes lead to insulin sensitivity. And that is when the body's not able to clear excess sugar from the blood using insulin. And insulin is released from the pancreas after you've had more of a sugar-loaded food. So occasionally that can lead to insulin regulation or insulin sensitivity issues as well. Occasionally, for those reasons, it can then be a little bit harder to lose weight. So there is some evidence that getting good sleep can help with some weight loss. Again, it's more through the other effects of balancing hormones as well. There may be some increased risk of tendinopathies. Often postnatal women, certainly that I've seen in clinic, have often come with things like decurvins, which is where you get your thumb extensor tendons get a little bit uncomfortable, often from lifting a baby that is continually growing. And so the repetitive loading and lifting, again, when estrogen levels are a little bit lower, might contribute to some of that aggravation of symptoms. So obviously as sleep duration increases, things will start to regulate a little bit better for hormonal function and also tissue repair. For the perimenopause group, there's a few points that changes in estrogen and progesterone levels can also lead to disrupted sleep. But that can then have more of an impact on day-to-day mental clarity and possibly also sports performance as well, if you're looking at your training or your competitions. There's about 39 to 40% of women experience sleep disturbance. So it's actually quite high, quite a chunk of the population. So it can influence lifestyle and day-to-day activities quite significantly. The long-term sort of sleep disturbance, they can have a bit of a increased incidence of certain other comorbidities, as they're known as, so cardiovascular issues, breast or uterine diseases, depression, anxiety, and sometimes also changes in cognitive function, which can affect moods and then have wider implications on social functions, quality of life of patients, people, general public, and that's before you even get to sort of athletic performance. So to manage sleep, there are some techniques, all is not lost. Various things like mindfulness, relaxation, reducing blue light exposure at night time before bed, with reduced screen usage, which is something we're obviously not doing tonight on this call. having a warm drink, no or reduced levels of alcohol. Try not to do high level intensity cardio for the 2 hours prior to sleep, as that will raise your core temperature. Cool dark room, and then maybe even looking at pre-bed routine. It's something that people often do with small children, but perhaps often gets lost a little bit when we get to adulthood. So there's a few things that can sometimes help. And then if you come on to the good bowel health, gut health, nutrition, hydration, generally if you're experiencing constipation and your fibre intake is not adequate enough, or your hydration levels also aren't high enough, and the body becomes constipated, that can have a bearing on certainly estrogen levels or hormone levels. So if you're normally through your cycle, obviously to get rid of excess estrogen in your cycle, your liver will clear out any hormones that it doesn't need. So that's excreted by the liver and then sent down to your bowel to be expelled. If your stool remains in your digestive tract, however, it can actually start to increase reabsorption of those estrogen chemicals marginally. And that might influence some other estrogen-driven issues like fibroids or endometriosis. So gut health is one of those things, as I mentioned, that Michelle Lyons is very keen on encouraging women to establish good gut habits, healthy bowel movements. If you've ever Googled the Bristol stool chart, it gives you a wonderful diagram of the variation of stools that a human body can produce, from liquid out of your rear end to rabbit droppings. You're wanting something roughly in the middle, sort of sausage-like stool really, so that it shows that you've got good gut health, good fibre and hydration levels as well. The other thing to consider is also alcohol intake. There is some evidence to show that there are much greater links between alcohol and breast cancer and alcohol and dementia, more so than HRT and breast cancer, which is something we'll mention in the menopause section, and also more so than sugar and caffeine as well when you're looking at diet considerations. So for perimenopausal, might be something you need to consider the intake for. The other thing is to also look at whether you're kind of wired and tired, as the phrase goes. So are you needing caffeine fixes in the morning to perk you up and alcohol in the evening to calm down? Those are generally not particularly long-term sustainable techniques to overall body health. And so trying to establish a slightly better routine with alcohol intake and caffeine will be helpful for hormone health as well. Plus, that might start to influence exercise performance and daily function. So the last bit about nutrition. So obviously nutrition, protein is quite essential for tissue repair, which we mentioned happens at night time when you're resting and asleep. And we'll also mention that the healthy fats in the diet are quite essential for the formation of sex hormones. So really you're looking at sort of carbs for energy, protein for tissue repair, and any triggers for gut issues. Emma will probably cover a little bit later on. And then you've got some stress level management. So again, trying to reduce daily stress is going to be quite key for hormonal balance. Elevated cortisol or stress hormones can have an influence on hormone balance overall. Sometimes what can happen is the body can actually start to convert progesterone into other sex hormones, into stress hormones, cortisol and adrenaline. If you're sort of continually exposed to this sort of fight or flight stress, long-term stress exposure. So try to identify any stressors. Might be work, family, competitions that are coming up, exams, children, older parents, other things in life that generally rev that engine of the sort of fight or flight response, so that you're not encouraging your body to convert that progesterone into cortisol and adrenaline that keeps you a little bit more fired up with stress. The other thing to focus on as well for perimenopause, postmenopause, is sort of belly fat as well. So sometimes menopausal women will mention a bit about the middle-aged tired, the sort of with the way the body lays down sort of the fat stores around the central abdominal area, and that fat is actually hormonally active. So generally, as your systemic estrogen declines as you're getting older, your body's trying to find other sources of estrogen, and it will find it there, but it's actually quite a metabolically damaging form of estrogen, that links with high blood pressure, diabetes, and obesity. So it's not really the form of estrogen that your body really wants to utilize, nor really that you want to necessarily have. So looking at management techniques for stress, again, there's lots of bits and bobs out there, but getting adequate support with work, family responsibilities, at any age or life stage, breathing techniques and relaxation, mindfulness apps or programs, self-care, exercise, which the majority of you will probably do regularly if you're on this talk from the Pacers or the Morton Hall Running Club, and also yoga, which can be a little bit more restorative. Movement wise, I mentioned strength training. It's quite a testosterone friendly form of exercise, and it increases what we call your serum testosterone, so your circulating testosterone. Generally, it's quite a good form of exercise to do in the first half of your cycle, as we've mentioned. For mobility and maybe premenstrual symptoms, you might want to do more sort of Pilates, yoga, and then cardio, you know, in the latter stage of your cycle, tends to be better. But having said that, if you do extreme levels of endurance or mileage, it can actually start to deplete testosterone levels as well in men and in women. So you might want to balance out some of the cardio with some strength training. Equally, sort of ultra cardio distances, running, you know, cycling, can be quite pro-inflammatory as well. So having an awareness of the recovery and rest periods is quite important there. And then when you're coming towards sort of post-menopausal age groups, exercise is quite important for reducing the risk of breast cancers, osteoporosis, osteopenia, which is the precursor to osteoporosis, so the reduction in bone density, and also heart disease. For any physios or coaches on the talk, maybe a consideration for the lower estrogen levels can be associated with a reduction in tensile strength, decreased collagen synthesis, muscle fiber diameter and density, and also increased degradation in tendon tissue. So when you're looking at your training schedules and your programs, have an awareness of those things that can occur in women in that age group. Just make sure that there's not an overloading, overusage, and injury risk associated with that as well. So in summary, so it's quite detailed in terms of the areas on the list, but as we go back to sort of sleeping well, reducing stress, good nutrition and hydration, good gut health, bowel health, and movement really are kind of the cornerstones to hormonal health, and then look into other things if there's still symptoms present as well. One point I am going to add on is a little bit on contraception. So obviously we've talked about the menstrual cycle, and that is for a woman who isn't on birth control. So what do you do when you have women who are? Generally, the function of contraception is to stop ovulation and prevent pregnancy. And it is safe to use, But there's also different ways that women can receive contraception. So typically that might be with a combined hormone, so your estrogen and your progesterone, which is designed to mimic a cycle. It doesn't have to, because you can take packets back to back, but because we're programmed to look out for some menstrual cycle with a bleed partway through it, that's how the contraception has been designed, so that we think that we're having a period, but you don't. It's actually a false sense of a cycle function in that breakthrough bleed. There was a post on Twitter and Instagram that Liz O'Riordan did this morning. She's a breast cancer surgeon who had breast cancer. And she actually did one talking about an article that had just been published stating that, let's find my notes, there is a risk of getting breast cancer, or the risk of getting breast cancer increases by 25% with use of contraception over our lifetimes, which sounds like quite a lot, but she goes on to break down the information in the study that really looks at, with the combined pill, you can have an increase in breast cancer after you stop taking it for several years after you've stopped taking it. And also the study was only looking at women on progesterone only contraception. So what they found, that women taking progesterone only contraception for 5 years, the risk of getting breast cancer in the next 15 years was 8 in every 100,000 women. So actually quite low. So if you wanted to have a little look a bit about that, she sort of dispels some of the myths on contraception and breast cancer risks. There isn't really the long-term studies for usage of contraception, birth control in women generally, whether that's sort of teenage, in your 20s, postnatally, because often that's something that women are offered at their 6 weeks checks. Have some birth control, and then also looking at HRT for either perimenopause or postmenopause. So there isn't really the long-term research behind that, but it is something that perhaps needs to be considered and looked at. Other forms of contraception might be things like the Mirena intrauterine system, or coil. That is one of the progesterone only forms of contraception, and that tends to work by thinning the lining of the uterus so much that it basically stops the period. And in some women it can also stop ovulation as well. And if you wanted a non-hormonal form of contraception, then you might have a copper coil, because as the copper is released, it tends to alter the cervical mucus, so that also influences the ability to become pregnant. There's loads of other information, obviously through your GP or gynae specialist, if you were looking at going on contraception, or you were on it and were thinking of coming off it. But there are lots of uses for it that are kind of positive, really. So in sport, for example, you might look at using it for scheduling events. I know on one of the podcasts I listened to, they were talking a lot about using it to schedule around, the Olympics or the World Championships or something. The last thing you want is to get your period when you've got a final event of a 100-meter sprint or something. Obviously, it can also be used for managing heavy periods for its normal form of contraception, and then for acne management as well, often prescribed to maybe teenage girls as well, or just to keep hormone levels at a more balanced, steady state without the sort of peaks and troughs of your estrogen and your progesterone through the cycle. So sometimes women will use it perhaps for 2 or 3 months to kind of give the body a bit of a reset, and then perhaps come back to those sort of foundations of improving hormonal health that we've just covered. Again, it really depends on your own individual circumstances as to why you take it and what you're taking. but from one of the courses I've done, as you get older and you've been on contraception for longer, there is some evidence that it can become more the pros than the cons of being on it. But again, further research into that and education really as to what works best for you is key. The main thing really about obviously hormonal contraception is that you are pretty much replacing your body's natural or endogenous hormones with synthetic or exogenous, as they're known, hormones, which again, there's sort of relatively poor evidence for the implications of long-term use. There can be side effects, but again, it really is personal choice as to how and why you're using it as well. The main thing sort of with younger girls, if there's issues with periods, often sometimes if there's acne or heavy periods early on in the first few years of getting cycles, it's difficult to know really what the cause is. Sometimes they'll be placed on hormonal contraception to try and minimize those symptoms, but possibly without looking at what the triggers, what the hormone imbalances are that are underlying those. It also doesn't allow you to track your cycles. So generally if you're on contraception, you're inhibiting normal ovulation process. So there aren't going to be those normal peaks and flows of estrogen and progesterone because you're not having normal cycles. So as you get older towards perimenopause and typically cyclical changes in the period will start to change, those are somewhat masked by the synthetic hormones. So it's something to be aware of, but not necessarily, you don't have to go and come off birth control just because you've listened to this talk, but it's a useful thing to be aware of, to look at the reasonings behind being on them for your own circumstances as well. So we're going to go on to the next slide. Which is perimenopause. And I've stopped flicking through them all. Okay. So as I've mentioned, perimenopause technically starts from the age of 35, when cycles can change. They might become heavier, irregular, longer, shorter. You might experience some other symptoms. And the typical fluctuations of estrogen and progesterone are generally more varied and slightly more unpredictable. Bit of a roller coaster ride for some women. Generally, you shouldn't get any bleeding in between periods. So if you do start to experience that, then get that checked. And some women, the closer they get to about sort of their late 40s, 50s, you might start to get some anovulatory periods where you don't actually ovulate. So your ovaries can still produce estrogen, your lining of the uterus can get thicker and thicker, but and that can result in heavier, more irregular periods as well.
Sorry, are we on the wrong slide?
Oh yeah.
Pause up.
There we go. I quite like the picture of the bear creature. I think it sums up most people's energy levels, I think, at this stage. Thank you. Yeah, thank you for that. Also, keep a check on any increased frequency of bleeding in between periods. So have your smear tests as well, because that can keep a check or indicate any changes in cervical cancer or onset of cervical cancer. So good to be aware of. For any considerations to training in sort of perimenopause stages, particularly if there's heavier menstrual bleeding, iron levels might be lower, so there might be some anemia, which can then have a knock-on effect to fatigue, an impact on energy levels and training as well. So those are things to consider and maybe speak to a GP about if you have any concerns. There are quite a lot of symptoms of perimenopause, which I'm going to read out to you. Again, these do come from Michelle Lyons. You won't necessarily get all of them, thankfully, but there are symptoms that I think a lot of women probably put up with and necessarily shouldn't. So here we go. Symptoms of perimenopause. The joy begins. So they can include hot flushes, night sweats, bloating, digestive disorders, increased body odour, particularly from the armpit, bone fracture, joint and muscle pain, breast tenderness, libido changes that go up or down, dental or gum issues, dry, itchy skin, pain or irritation with bowel movements, recurrent UTIs, urinary urgency or frequency, anal leakage. And I said to someone the other day, 1 in 5 women over 40 can experience anal leakage. Constipation, heaviness or bulge in the vagina, so sort of prolapse type symptoms, vaginal dryness or itching, pain or bleeding with sex, difficulty orgasm, hair loss, weight gain, heart palpitations, headaches, migraines, disrupted sleep, itchy, twitchy or restless legs, decreased energy, tiredness all the time, rumination or catastrophizing, panic, irritability, brain fog, difficulty getting or staying asleep, decreased concentration, anxiety, decreased confidence, depression, decreased joy, rage, irregular changes in periods, flow, pain or timing, dry, irritated tissues, clitoral or labial shrinkage. I'm not entirely sure how that's measured. And also finally, bladder leakage. So as I mentioned earlier, some of the postnatal issues of stress urinary incontinence or urge incontinence, common but not normal, but also can be present in perimenopause and postmenopause if they're not tackled. So if you're looking at coaching considerations for the perimenopausal women, that's quite some list of things that women might be battling with quietly in the background, and they do often have slightly wider implications to social, physical, emotional impacts on women, and can be barriers to participating in sport as well. So there are lots of things that we are probably programmed to just accept as normal and that we get on with, but a lot of those symptoms can also be managed and improved if the overall kind of care is quite an individual approach. Again, looking at the foundations of hormone balance, and then any other kind of management medically, possibly with things like HRT or topical estrogens, for example, to help with quality of life as well. Coming on to the menopause. So when there's a lot of stuff in the news about menopause, or has been certainly over the last few years, but actually a lot of that really relates to the previous slide, so the perimenopause, which is from the age of 35 up to, on average, 52, which is when most women have a year or 12 months without a period. So retrospectively looking back, that is when you say, oh, okay, now I am postmenopausal, and then you're kind of living or tackling the impact of aging from that point onwards. So generally you're then dealing with a drop in hormone levels unless HRT is a management option for symptoms, and hormone levels really become lower but more settled. Some women might experience some sort of carryover of symptoms from perimenopause, but they may not. So again, it's quite individual. What one woman will experience will be quite different to someone else. And again, it's really knowing what your norms are sort of throughout your menstrual years, antenatally, postnatally, perimenopausally, so that then you can monitor changes when you get into the postmenopausal stage. So yeah, menopause is really the 1 year that you don't have any periods. Perimenopause is the sort of 10 to 15 years leading up to that. And then postmenopause from that point onwards. The decline of your estrogen levels can have an effect, as mentioned earlier, on your heart cells, the endothelial cells. And that is why often postmenopausal women have an increased risk of dying from heart attacks or heart disease. And it's actually the biggest cause of death in women, not breast cancer, primarily because the presentation is different in women, so it's not picked up as quickly. Often it can be as sort of instant as death, but symptoms can present as shortness of breath, feeling or being sick, or back or jaw pain. So in a man, it might be the kind of typical left-sided arm or chest pain. So it's something to be aware of with symptom presentation in women. It's not something that's widely talked about, but can be something that women in that postmenopausal age might experience. The muscle mass in our bodies starts to also decrease. Approximately 3 to 8% a decade after the age of 30, if no sort of regular exercise is completed. And that rate of decline is even higher after the age of 60. So the strength training elements of hormone management and general fitness are quite key to either maintain or improve muscle mass in our bodies. With women postmenopausally, they're also twice as likely to get dementia. It's a really happy list of things that we experience postmenopausally. Again, primarily because estrogen is brain protective, and when that level drops, that can have an influence on prevalence of dementia. So I don't know that that's as high if women are then on HRT, so the hormone replacement therapy, but certainly in those without, it's something to consider. Training considerations for the postmenopausal women. 1 in 4 women over 50 will experience a gluteal tendinopathy, so a bum cheek muscle tendon tendinopathy, again due to that reduction in estrogen levels. And a similar for shoulder rotator cuff issues. So for anyone who does triathlon or swimming here and is into that postmenopausal age group, that's something to be aware of in terms of the repetitive nature of swimming on the rotator cuff muscles. There's also an increased risk of metabolic diseases, so your high blood pressure, hypertension, type 2 diabetes, and that can be due to changes in body composition and that increased body fat that I mentioned that can be hormonally active as well, plus loss of lean muscle tissue. So your HRT obviously is an individual consideration. It can be very good for replacing estrogen and the consequences, excuse me, of experiencing lower levels of estrogen. But also you need to have a look at quality of life considerations as well. So bone health is quite a big factor if you're not on HRT, with risk of fragility fractures from osteopenia or osteoporosis being quite high. But we can prevent these issues as well. So on a slightly more positive note, from all the things that women can experience, with various ways of managing things, so good lifestyle, nutrition, diet, hydration, and exercise management as well as we age. So you still want to challenge the body, but be mindful of changing symptoms. And then we come on to red S. So excuse me, I've got a tickle. So what is red S? So it is the relative energy deficiency in sport. In a nutshell, there is not enough energy intake to meet the demands of physical activity and exercise and energy output. And hormones are directly affected as a result. one of the key things that can happen is the onset of irregular or even non-existent cycles. So it plays havoc with your ovulation and or stops that happening. One of the problems with that, and there are a few, is that it can also point to serious health issues in the medium and long term, which can also be associated with lifestyle, stress, endocrine, gynecological, autoimmune, nutritional and genetic disorders. So estrogen and progesterone, as we mentioned, are produced as a result of your ovulatory process within a normal menstrual cycle, and they support your brain health, bone density and health, heart health, cognitive function, sleep regulation, breast and uterine health as well. So those factors are directly impacted by a healthy, unhealthy or absent menstrual cycle. RED-S can affect men, and typically in the pictures on your slide, there is a sort of prevalence in a certain sporting physique, I guess. So you've got your ballet dancers, your gymnasts, your endurance runners, your jockeys, basically anyone who has to maintain a relatively low body weight, or also someone who is doing a lot of training, which we'll come on to. Generally speaking, there's 20% higher prevalence of disordered eating in athletes versus non-athletes. And that was from a paper in 2018. The prevalence of musculoskeletal disorders, so muscle, joint, skeleton problems in women who self-reported menstrual irregularity was about 81.1% for oligomenorrhea and 69% for amenorrhea. So those are quite high, really. Amenorrhea is when periods stop completely because there's not enough energy for the body to actually bother with ovulating. Oligomenorrhea is when periods are so irregular that you might have about 6 to 8 over the course of a year as well. So as I mentioned, so common sports that RED-S can be found in, so gymnasts, dancers, runners and jockeys with low body mass and more of an ectomorph body shape. Signs and symptoms, so these are really quite important to be aware of, with restrictive or disordered eating, so maybe verging on your anorexia, your bulimia, a focus or preoccupation with food, overtraining is massive, weight loss, and then low energy availability as well. Sometimes there can be some personality type contributing factors as well. So often there's a high drive, perfectionism, type 1 driven individual, obsessive tendencies as well. So real high achieving individuals, and also environmental factors as well. Aesthetics, social media is awful for this kind of thing. Appearance, perceptions from public, family, social media, even coaches. So there can be a little bit of overlap with coaches sometimes fueling the onset or development of sort of RED-S behaviours, typically when perhaps athletic performance starts to improve, speeds, times, durations of distance improve, or your speeds of your races improve. Weight might change as well, but there is a bit of a sweet spot before things start to decline, and that energy balance is tipped as well. So the RED-S, it really compromises long-term health, which is the main thing, and also athletic sport performance, and that cannot be stressed enough. It's not normal to not have a period and not ovulate, particularly because your body just won't have enough energy to maintain reproductive health. Sometimes the issue can excuse me, just be that there isn't sufficient energy intake, as opposed to it being disordered eating. There is a bit of a grey area and a fine line. One thing that might be quite useful to try and establish what your baseline levels for energy intake is through finding out what your basal metabolic rate is. So basically your energy baseline, what energy your body needs for day-to-day functions in your sort of your brain, your vital organs, and living, before energy expenditure is taken into account. And that's something that you can look at online, I think, and put various things into tables that come up with your sort of calorific, if you like, intake of energy. So that's quite useful to then gauge whether or not you're actually not providing your body with enough energy to really kind of maximize your training efforts as well, because that's what it's all about, performance but safely. Symptoms which can also appear if people are on contraception, and obviously if you are on contraception, it's very difficult to know if you're not ovulating, because you're not ovulating as the contraception suppresses your ovulation. So if you've lost your periods, then that already flags up problems. If you're on contraception and you get any of the following issues, then it might be worth having a look at what your energy balance is with food in and energy output. So loss of periods, niggling injuries that just don't quite settle, lots of regular colds and infections, perhaps some development of some stress fractures or repeated stress fractures, feeling tired and fatigued, tendinopathies, low iron levels, anemia, fatigue. It can slow your digestion as well, so you might experience some bloating or IBS symptoms, and possibly also some poor sleep. So basically your body is breaking down, primarily because there's too much energy output, not enough energy input. You know, if you were driving your car up to Scotland, you wouldn't expect it to get there on fumes. So when you're training, you really shouldn't expect your body to perform at its peak when you're not fueling it adequately. So really, as I say, you could look at support when athletes are unable to identify these behaviours or changes in symptoms. So that really needs to come from the support team, coaches, and for maybe the wider club, group, family members to have a bit of an understanding of symptoms, so that there's some implementation of management to help the athlete get back on track with good nutrition and hydration and good behaviours really behind fueling fitness. There's quite a common misconception that you know, you need to train more, run more and do more and eat less to perform well, but actually the way that management of RED-S is approached is actually by eating more and doing less, which can feel quite backward, particularly if you're in quite a pattern of regular training. But we're often conditioned to believe that you know, doing more miles and eating less is the way forward, and it really isn't. The other thing to look at, just as an aside, for young girls, so teenagers, late teens, early 20s, if there are sort of perhaps signs of some of these RED-S symptoms, is with regard to bone health. So about 95% of a young woman's peak bone mass is present by the age of 20. And that is generally achieved through sort of loaded exercise, calcium intake. I'm sure Emma will be able to talk a little bit more about some nutritional elements there. And there's also some overall gains in mass, bone mass, continuing up to 30. But typically by your early 20s is when our bodies are at peak bone mass. If that's not achieved by that age, through low energy intake, low calcium, vitamin D, protein intake, low body weight or sustained low body weight, disordered eating, low bone loading or strength exercises, it can have implications to bone health as we age. So not only at your perimenopausal age, but also postmenopausal. Again, when you're looking at fragility, fractures, osteopenia and osteoporosis as well. So there's quite a few things to think about with Red S. I mean, you could look at for the young females, there's wider societal reasons why physical activity is changing, with sedentary behaviour, social media, reduction in activity in schools, obesity, lack of provision or access to sport and exercise, and even cultural and religious factors as well. So it's not quite as straightforward a thing to manage, but for the Red S, certainly having the kind of warning signs there with changes in behaviour habits, training levels, weight changes and energy intake are the main things to consider, and then try and rectify and improve for hormone health, and then also general health overall as well. We're nearly there. So now come on to considerations for coaches. So this is where I mentioned the slide from Kirsty, Elliot Sales paper I have stuck on here, and you might have to get your face quite close to your screen in order to actually read some of the text. It is on obviously an A4 page on a PDF online if you go to Google Scholar, so it's easy to access. But what that does really is, if you're looking at the female menstrual cycle, what it covers is sort of different phases, and so you've got hormone level variations, physiological and psychological changes, the effect on training at the 4 or 5 weeks of a cycle, and then you might have a look at what type of exercise you do. So the focus basically looks at whether you're looking at aerobic exercise, strength training, recovery, rest, that kind of thing. So you can use it for your own usage. There are some exercise apps that do actually sort of schedule exercise based on your cycle as well. So this is probably where some of this data comes into those algorithms and exercise programs. And there's no one size fits all for female. There's lots of considerations to consider for men that coach women and women that coach women as well. But there are differences in our bodies, obviously, physiologically. Our anatomy is different, our endocrine systems are different. For women, it can be different if you're on contraception versus not. And there's also psychological variations, so a much bigger picture of what's going on in someone's life can influence sporting performance and training ability as well. And the other thing to mention also is breast health as well. So that comes down to things like size, hormone influence, sports bras. Sports bras are a massive topic. I mean, there's a lot of women that are probably wearing the wrong bras. And actually the influence of hormones on breast health, generally, you might venture into breast cancers as well, but generally speaking, the loading of that tissue through exercise, running, higher intensity exercise is also something to be aware of. So differences do need to be considered, particularly with strength and conditioning programs as well. Another factor as well, children and teens, if they are part of a training group, running or otherwise, are not many adults, and women are not small men. So when you look at things like a female's absolute whole body strength, so a 1 rep max, we lie about 60 to 63.5% of a man's absolute strength. For upper body strength, we're about 55% of a male, and for lower limb, you're looking at about 72% as well. So training is going to be different, men versus women, and then throughout menstrual cycles versus not, if you're on contraception. And a lot of the training considerations really perhaps need to start looking at, women in the menstrual years, with and without contraception, pregnancy, postnatal, physiological changes, perimenopause, and then into that postmenopause, whether women are on HRT or not as well. So that leaves quite a lot of things to think about in terms of how training schedules, programs are structured, particularly if they're group ones as well. I know from going down to the paces at the track, everyone is doing the same track session, but there will be women there who will be at different stages of their cycles, different symptoms, different injuries, niggles and things. So maybe one size doesn't always fit all with a training program. The other thing to mention on the postnatal women is, if you haven't seen it already online, to Google the Return to Running guidelines. So there's a couple of women's health physios, Emma Brockwell and Gráinne Donnelly, who wrote them alongside a list of other professionals. And they are available as a PDF download. So when you're looking at Return to Running guidelines, they are guidelines, and the majority of them, because women's health research is somewhat lagging behind the rest of the world, there are some studies that have come from male studies, but they do give a foundation really for women who are looking to get back into running, whether that's recreational or to county level, race level, elite level, depending on what you do, who you are, and what elements really you want to look at in your physical ability to then progress on with a phase of rehab. So they're really good if you haven't come across them, because they really cover sort of a program really up to 12 weeks if you're looking at conditioning. So the prep really to get your body stronger, and then the requirements for 12 weeks plus. And then really everyone in those age groups needs to sort of consider some strength training and integrate strength training with running. I've come across a few people recently in clinic who run and perhaps don't really do quite enough strength training to balance the cardiovascular side of fitness as well. So that's where sometimes you can get a bit of dominance through certain exercise types, I guess, but sort of getting a balance with the mobility, Pilates, yoga, strength training, so more than body weight, perhaps with dumbbells, resistance bands, or heavier into your Olympic weightlifting, deadlifts, clean and presses, that sort of thing, where you're then looking to achieve greater strength gains as well. Those have, as we've mentioned, good physiological impact on the body for prevention of bone health issues, your osteopenias, osteoporosis. But particularly with running, just because you're doing strength training, it doesn't mean you're going to bulk up and your times will get slower. Often, if your conditioning is there, it will complement your cardiovascular training as well. So I will stop filling your ears with my sultry tones and just summarise really a bit of a whistle-stop tour of the main phases, or the only phases really, of female life stages. So you've got your menstrual cycle, your antenatal, which we haven't really covered too much, but postnatal time periods, perimenopause, postmenopause, and then the red S, energy disorders in sports considerations. The main things, if you're going to summarise from the last 55 minutes, is to track your cycles and symptoms if you're not on contraception. Establish your baseline energy requirements so you don't have to move into an energy deficiency with overtraining and therefore experiencing or potentially developing subsequent hormonal imbalance, and help your hormones as well. So adequate sleep, stress reduction, nutrition and gut health, hydration, and then movement, cardiovascular, mobility, and strength exercise. So that's me done for this section. I will move on to Emma's slides The further info slide just gives a little bit more information on links. If anyone wants a copy of these slides, please email me because I'll send them out. And Emma, if you want to unmute yourself.
Can you hear me okay? Okay, thank you, Anna. I'll just sort of talk for the next 10-15 minutes or so, and I'll just go through some nutrition and lifestyle tips in relation to hormonal health and hormonal balance, and hopefully just some things that you can consider and take away and start to put into your day-to-day. So I'll focus mainly on estrogen as the hormone, and excess estrogen really, and ways to help to lower the excess estrogen in the body, because it's usually that excess estrogen that's associated with a lot of the hormonal symptoms, fertility issues, irregular periods, PMS, as well as conditions like endometriosis, fibroids, and polycystic ovary syndrome as well. So I'll talk a little bit about xenoestrogens. So xenoestrogens are in products that we use in our environment and in certain foods that we use on day-to-day basis really, and they're chemically very similar in structure to estrogen. So they come in and they act in our body in a similar way to what estrogen does. So when you consider that we've got our natural estrogen in our body, and the cycle as Anna described, and then when we have other compounds coming in and acting like estrogen does, it can just perpetuate that load and then lead us to be in a sort of overloaded estrogen state, which isn't what we want, or what we want to try to minimize. So the xenoestrogens are commonly found in pesticides and insecticides. So any sort of non-organic fruit and vegetables, grains, you know, in farming will most likely use pesticides and insecticides. So it's just being mindful and making sure that things are washed well. Obviously, just water isn't really gonna remove them totally. So acidic mediums are quite good. So adding lemon juice to water or vinegar to water, that can just help to break it down a little bit better. And then peeling where possible, because most of it will be on the skin of the fruit or vegetables. And then it's sort of eating organic where you can, because in organic farming these won't have been used, but obviously it's not realistic for everyone to eat totally organic, but just where you can, because it just will help to reduce the overall exposure and what you're sort of eating. So yeah, fruit, vegetables, grains, oats, and wheat products, just being mindful of that. Another thing to consider is skincare products. So obviously these are things that we're using on an everyday basis, makeups as well, shower gels, soaps, sun creams, and lotions and things. And they can contain certain chemicals that act as these xenoestrogens in our body. So parabens is quite a common one, and it's usually written on the label as methylparaben or butylparaben, so you'll see it as the last part of the word. Benzonophine as well is a common one, and phytalates as well, which you'll see as DP, DBP, and DHP. So to help to reduce exposure to those is looking for more natural based products. A lot of products will say on them paraben free or natural origin based, 95% natural origin, and they'll sort of really advertise it on the label there, so it's usually quite clear and noticeable. And then plastics is another common one. Common chemicals in the plastics is bisphenol A, usually called BPA, and the phytalates as well. So this can, not drastically, but a little bit come into the food or drink that's being stored in the plastic container. Heating in it is not so good because it just causes more of a movement out of these chemicals. So some tips are sort of using stainless steel water bottles where possible, reducing plastic usage, plastic water bottles, and avoiding kind of keep refilling shop bought plastic water bottles as well. Not keeping them in hot cars and things on a hot day. Trying to use other things instead of cling film as well. And then using glass containers or bamboo containers rather than plastic Tupperwares. And then avoiding to heat in these as well, because you know, the ready meals or things that you buy in the plastic containers, putting them into glass or another microwavable dish can be helpful. So now I'll move on to phytoestrogens. So phytoestrogens are compounds that are more sort of beneficial for us, plant compounds. And again, they're chemically similar in structure to estrogen, and they come into the body, bind onto the receptors, and they can take the place of estrogen on the receptors there. But they have a much, much weaker role than estrogen itself. So it can therefore be quite beneficial to help with that excess estrogen load, reducing some of the effects of the estrogen in the body. And it can help to metabolize and break down, and also help to support that detoxification through the liver of the excess estrogen as well. Phytoestrogens are also really beneficial for menopausal symptoms as well, the research is showing, and that's just because of that similar structure it has to estrogen, and obviously the decline in estrogen, it can just help to replace some of that, but in a much, much milder way, so onto the estrogen receptors. So good food sources are soy products, tofu, tempeh, dami beans, things like that, legumes, chickpeas, beans, lentils, adding those into recipes, and seeds, flax seeds are particularly good, grinding them, so it can just help to be absorbed as well, the phytoestrogens from the flax seeds. Sesame seeds, and oats, rice and wheat bran as well, good sources. So Anna touched on this a little bit earlier, but stress and that impact on our hormonal levels and sort of driving that excess estrogen. So it's that long-term constant stress, you know, on an everyday kind of basis that's going to have an impact on the hormonal levels. And it's that cortisol and adrenaline that is being pumped out in that fight or flight response. You know, in hunter-gatherer times, they'd fight the animal or they'd run and they'd burn off all those hormones. These days, we're just having that response and we're not burning it off in any way. So it's then having that effect in the body. On the progesterone receptor as well, cortisol always competes with progesterone, and cortisol always wins, so pushes progesterone out. And progesterone is quite calming and also fat burning as well. So it's just also having that negative effect of pushing progesterone out, but also cortisol can then perpetuate that estrogen dominance. So it's doing things, as Anna said, you know, going for a walk, doing things you enjoy and having that downtime, mindfulness meditation and things. And there's lots and lots of apps now that can have guided meditations and things, which can be really good. This is a little bit on the liver detox of estrogen. So the liver will go through a number of phases to break estrogen down into a simple form that can then be reduced and eliminated. And DIM is a compound that really supports this detoxification process of estrogen to help to reduce estrogen. So the green leafy vegetables and all the cruciferous vegetables, which are listed there, can be really good sources of the DIM to just help that overall detoxification. And then when it is in its simplest form, then then fibre is really important, because then the fibre comes along, binds to that to that estrogen and then is eliminated through the through a bowel movement. So it's important to be having lots of fibre sources, plant-based products, vegetables, fruit, grains and things, and legumes, beans, nuts and seeds as well in our diet. So and as Anna said, digestive health is really, really important when it comes to hormonal health, and they're often sort of that hand in hand. People with IBS or constipation issues may then see and find themselves having sort of hormonal issues, and it is usually because of this process of that reabsorption of estrogen if it's not effectively removed. So yeah, so that's it really for what I'm going to talk about. But I'm a nutritional therapist at Peri-Physio and offer one-to-one sessions with people. So if you're interested, then please do get in touch. My email address is just there, but I help support clients with hormonal issues, perimenopause, menopause conditions like endometriosis and fibroids as well, and many clients with gut issues as well, food intolerances and IBS. So and because they're so hand in hand, often they kind of present with both as well. So thank you very much for listening, and I'll hand back to Anna now.